welcome everybody to the highlights from the American Thoracic Society Conference. And we're very grateful and honored to have Professor James Chalmers with us today. So if you don't know us here at Running on Air, we are a nonprofit in the United States, and our mission is to help others breathe more easily through access to oxygen appropriate to their needs. Our focus is on advocating, informing, and reforming through raising awareness, promoting policy changes, and educating patients and providers about supplemental oxygen and lung diseases, especially primary ciliary dyskinesia and bronchiectasis. You can follow us on our social media accounts, and on Facebook in particular, I'll be sharing in a moment some of the information we're sharing in June. Webinars like this are part of our conference highlight series. There's a lot of conferences that go on throughout the year on bronchiectasis or PCD, not maybe specifically bronchiectasis, but there's a lot of going on in the world of bronchiectasis these days. But there is the World Bronchiectasis Conference happening in June in Germany, and we have 2 webinars coming out of that. So the first one will be by Dr. Ann O'Donnell on July 1st, and she'll be giving the highlights of the conference. And then the next day on July 2nd, we have Dr. PJ McShane with the NIH, and she'll be going a little more specifically into the heterogeneity of bronchiectasis. And that's one of the topics I'm excited about hearing at the World Bronchiectasis Conference. But we also have other conference highlights throughout the year. PCD on the Move in August, the European Respiratory Society Conference in October, also CHEST, and the North American Bronchiectasis and NTM Conference in December. So if you do follow us on Facebook, you will be seeing us post facts about bronchiectasis throughout June. World Bronchiectasis Day is July 1st, and in the lead up to that, we're posting a different fact every day. It's a great way for maybe you to learn more about bronchiectasis, but in particular to help raise awareness by sharing these facts on your social media pages. Now, usually, so we're doing this webinar in partnership with NTMIR, and usually Amy Leitman would be joining me as moderator, but Amy is traveling today, so John Torrance is playing the role of Amy Leitman. Thank you, John, for being here.
Thank you, Mary, for having me. It's always a pleasure to work with you. NTM Info and Research serves patients living with NTM lung infection and bronchiectasis. We're here to provide education, support, and advocacy for our community. And the good news is many of our resources are completely free, and you can access them simply by visiting our website. On our website, you'll find our network of over 50 support groups where you can connect with others who truly understand what you're going through. Our online patient forum, NTM and BE Connect, the BE standing for bronchiectasis, is a space to share, ask questions, and find community. And our YouTube channel is filled with educational webinars just like this one. We're also thrilled to announce the launch of our new Bronchiectasis Insight pamphlet written from a patient perspective. You can scan the QR code on this slide to order your free copy. Coming soon, we'll be expanding our resources to include materials on nutrition, emotional well-being, a caregiver resource, and extrapulmonary NTM infection. So there's lots to look forward to. Also, please save the date. August 4th is World NTM Awareness Day. We'll soon be announcing a webinar series throughout August to celebrate, so stay tuned. And last but not least, please follow us and stay connected. This slide has all of our social media handles and contact information. We'd love to hear from you. Mary?
Thanks, John. And I just want to mention that you may not have had your phones ready to scan that QR code. So we will be sending out a post-webinar email by the end of the week. And we'll have the links that are mentioned, that John mentioned in the. So just a few housekeeping items. This webinar is being recorded, and we will be sending out that recording in a few weeks once that is up on our YouTube channel. We will not be taking questions during the webinar, so please don't raise your hand. If you do raise your hand, we'll be ignoring it. Sorry. Put your questions in the Q&A, and we will be getting to as many of those as we can. But please remember that Professor Chalmers can't give medical advice. You can ask general questions, or if you want to phrase your question more generally, but if you ask a question specific to your case, we won't be asking that, as he cannot give medical advice. So as I mentioned, you will receive a post-webinar email by the end of the week, and that'll have the links and resources that are mentioned in the webinar today. And then you'll receive a second post-webinar email from us once that recording is up online. Great. John?
So Professor James Chalmers is the Rhodes Chair of Experimental Therapeutics at the Radcliffe Department of Medicine at the University of Oxford. He's a pulmonary physician specializing in bronchiectasis. He cares from around 1,000 bronchiectasis patients in the UK and has worked on bronchiectasis research for 20 years. He is chief editor of the European Respiratory Journal and chairs the European Bronchiectasis Registry, as well as being chair of the British Thoracic Society Standards of Care Committee. He has published more than 550 peer-reviewed publications and leads a translational research group focused on development of new therapies for bronchiectasis. It's my great pleasure to introduce Professor James Chalmers.
Thanks so much, John, and thanks also to Mary for giving me the chance to speak to you all today. Both Running on Air and NTMIR do wonderful work to support patients, and you'll see when I come to the presentation that we're seeing a lot of new science coming through in bronchiectasis, and a lot of that is because patient advocacy and patient organizations have really pushed for this disease to be recognized. And ATS was another example where I thought we really were recognized. Bronchiectasis was everywhere. Lots to discuss, and lots of new data. As John just introduced, one of my major interests is new treatments for lung disease. And so a big focus of what I'm going to show you today is really the updates on new treatments for bronchiectasis that were coming out of that conference. So hopefully lots to discuss. I'm delighted to take questions. I'm going to talk for about 30 minutes, and that means that we've got 45 minutes easily for questions. So please ask me anything you want to know about the ATS, about what the data that I'm going to show you, but also anything about bronchiectasis or NTM more generally, and I'll be delighted to try and answer those questions. So here we go with the highlights from the ATS conference. Before we start, of course, it's important to remember that I work with a number of companies to make and to help make new treatments for these diseases. And of course, I'll talk about some of those as we go through the presentation. So I'm going to start with the new anti-inflammatory drugs for bronchiectasis. Many of you will have heard of these. They're called the dipeptidyl peptidase 1 or DPP1 inhibitors. And the first to be approved by the FDA was Brinsupri last year, brensocatib. This is the first treatment to be licensed specifically for bronchiectasis. Really exciting when this came out last year. Brinsupri reduces exacerbations in patients with bronchiectasis at 2 doses, the 10 milligram and the 25 milligram dose. But also, as you can see here, this is the lung function over time, and people with bronchiectasis, particularly if they have a lot of exacerbations, the breathing tests, the lung function tests get worse. And that decline is prevented by the 25 milligram dose, but not by the 10. So that's an interesting finding and something potentially quite important. I've recently published a paper with Chuck Daly from National Jewish, because both the 10 milligram and the 25 milligram dose are available in the United States. And in that paper, I say I think people should ideally take the 25 milligram dose as long as they're not having any side effects, because it seems to have more benefits. So on that topic, good timing, at the ATS, the company presented some data looking back at the two big trials that have been done with Brinsupri. And this is pharmacology. So this is the study of drugs. So this is complicated even if you've had medical training. So I'm going to make it as simple as possible. They've measured, after people have taken the drug, they've measured how much drug is in the body. And you would think after you take a dose of medicine, the amount of drug would be the same in everybody. But of course it's not, because some people are bigger, some people are smaller, some people metabolize drugs more quickly, some more slowly. Some people will be taking other medicines that will have some effect on how these treatments are dealt with in the body. And so some people will have high levels of the drug in their blood, and some people will have low levels of the drug in their blood. Does that make sense? Okay, so then they looked at the relationship between those benefits, like having less exacerbations and having better symptoms, and how much drug was in the blood. And importantly, what they show is that people who have higher levels of the medicine in the blood had less exacerbations, or were more likely to have a benefit on exacerbations. Yeah, they had a look at the different doses, and of course, because the 25 milligram dose is a higher amount, more people are above that threshold that you need to benefit from the drug if you take the 25 milligram dose. Okay, and so 99.4% of people, as it says here, were above that level, or above this high level in people who were receiving the medicine. And it looked like people who had those higher levels were getting also the benefit on lung function that I mentioned earlier. So what it tells you is that the amount of drug, the more drug that's in the body, the more likely you are to benefit from the treatment. And there didn't seem to be a relationship between that amount of drug in the body and the side effects like skin problems. And so it supports what several of us have been saying recently, which is if you've got a choice between the 10 milligram and the 25 milligram dose, taking the 25 milligram dose means you're more likely to get the right amount of the medicine in your body. So that's what that's a summary of some complicated science, but potentially quite important. So brensocatib is not the only DPP1 inhibitor in development. So it's the only one that's FDA approved. But hot on the heels of brensocatib is another medicine called verducatib. Sounds very similar, and it's the same class of drug. It's another DPP1 inhibitor. The idea of having more than one drug in the class is sometimes you see differences between these medicines in terms of how they work. Some may have more or less side effects. And so it's often helpful to have more than one medicine within a class of drug. This drug, verducatib, was tested in a phase 2 trial where they showed reduced exacerbations, very similar to brensocatib. And the 2.5 milligram dose of verducatib's now gone forward into a larger, what we call phase 3 trial. That's the trial just before it's able to apply to be approved. Now, they did something unique in that phase 2 trial, which was that they also allowed patients who were in the trial to continue taking the medicine for longer. So normally you would stop at 6 months or a year, and that would be the end of treatment with the medicine. But in this trial, patients were allowed to continue for up to 3 years. So I'm going to show you data now from a trial called Clearleaf, which is called a rollover trial, where people took the medicine for more than 3 years. And why is that important? Well, the largest trial we have of these drugs so far is 1 year. So being able to say what happens over 3 years gives reassurance to patients that there's not important side effects or problems with these medicines. So this took everybody that was part of that Airleaf trial, which was a multi-center international trial, 322 people with CT confirmed bronchiectasis. Everybody was 18 to 85 at the time of treatment and had a history of exacerbations and was coughing up sputum at the first visit. Notably, NTM patients are not in this study. And so everybody who went into that trial was eligible to cross over into the rollover trial for 3 years, which is called Clearleaf. Importantly, though, we don't want people taking a placebo tablet forever. And so people who are on the placebo tablets were randomized to take one of the 3 doses of the drug, either 1 milligram, 2.5, and 5. So in the original trial, there were these four approaches, including placebo. Now for the 3-year period, everybody's on one of the 3 doses of the drug. Hopefully that makes sense. So all the people we're going to see had at least one level of dose of the drug. And in the original trial, which was up to a year, the 2 doses that worked were the 5 milligrams and the 2.5, and they reduced exacerbations by about 30%. And you can see the 1 milligram didn't work so well. It only reduced exacerbations by 7%. But that's an important number because that number is not 0. The 1 milligram is still doing something, but it's doing something much weaker than the other doses. So this, because the people in the rollover study for up to 3 years are taking either the 5, the 2.5, or the 1, you can see whether over the longer term, these 2 doses are still beating the 1 milligram. Yeah, it doesn't tell you what it would do against a placebo, but it tells you would it beat the 1 milligram. And this is the results now up to 3 years. And this is great to see. So we've now got data on these medicines for up to 3 years. So what these numbers over here mean, 0.79, the easy way to express that is that's a 21% reduction in the risk of an exacerbation in the 2.5 milligram dose and 7% reduction for the 5 milligram dose. And that's compared to the 1 milligram. So there's no placebo here. So if you wanted to be very crude about it and try and guess what the difference would be versus placebo, you could try and add 7% to these numbers, but I wouldn't do that because we don't know what the 1 milligram would have done over a 3-year period. But what it says is that the 2.5 looks as if it's giving a sustained level of benefit, the same level of benefit over the 3 years as we saw over the first 1 year. So that's really reassuring. But we're going to have to wait for the big phase 3 trial to find out for real how effective this new drug is. What the 3-year data really helps us with is to answer the question, how safe are these drugs? Yeah, how many times do patients experience side effects? And so that's what this is now. And this is very, very reassuring. So what you see is that the number of side effects is recorded here. So over, out of all of these patients, most patients will report something over that 3-year period. That is not surprising because we report everything. Even if you stub your toe, that gets reported as a possible side effect. What matters are the side effects that we know can happen in people who take these kinds of drugs. So there's a rare genetic condition where this DPP1 is gone completely. And what people get in that condition are dental problems and skin problems. And so we look carefully for dental problems and skin problems. And so here we go. Here's the skin. Out of 100 people, around 100 people, 7 people got skin problems in the placebo group. Then if we go over to the pooled data, which includes the 3-year Clearleaf data, over 3 years now, only 8 people in the 1 milligram and only 7 people in the 2.5 milligram group got skin effects. So they look a lot like the placebo, even though the placebo is only 1 year of data. Yeah. And then we look here at the 5 milligram, it's a bit higher, it's 20, isn't it? But the number of people in that group is much higher. So that makes it look higher than it is. It's actually only about 15% or 1 in 8 of the patients or thereabouts. So the number of side effects is not very high, and these are not causing people to have to stop the medicine. The 5 milligrams not being developed anymore. It's just the 2.5, and that looks a lot like the placebo, which is very reassuring. And then the dental stuff also looks really reassuring. So there were only 5 during the 1-year study, the Airleaf study in the placebo group, and very, very similar numbers in the treatment groups. Now you go out to 3 years and 7, 7, and 8. This is a population of people who are over the age of 65. So all of us at some point in our lives will have some kind of dental problem. But over a 3-year period, these numbers look very much like the numbers that you see in placebo. So I'm feeling pretty good about the long-term safety, at least over 3 years, of these new medicines. And that's some really useful data. there's still lots of unanswered questions about DPP1, and there were lots of discussions at this conference about, how are we going to pick the right one? Should we pick the 25 milligram dose, or would you start lower and then increase it if people are not having side effects? Knowing which patients we should start the medicine in first is a really important question, because the FDA approval currently says treatment of non-CF bronchiectasis without specifying which patients and at what stage of the disease. So there's lots of unanswered questions, as summarized in one of these figures that was shown at the conference. Okay, so that's the story with DPP1 inhibition. I should have said at the beginning, I've got sort of 3 parts to my talk. The first is on new treatments for bronchiectasis, which is the DPP1s. The second is on gene therapy for PCD. Then I'll talk a bit about NTM, and I'll finish with some new antibiotic type treatments. So let's briefly talk about gene therapy for PCD. And this is obviously a really exciting area and something that's super important. We know how effective and transformational the modulator drugs that fix the cystic fibrosis defect have been. Wouldn't it be wonderful if we could find something like that for primary ciliary dyskinesia? Well, at the conference, there were 2 studies that were presented, and these are the phase 1 trials, the phase 1b trials of a DNA-I1, that's the name of the gene, RNA treatment. So I'll explain what that means. So what that means is that you're taking, you've got a faulty gene that causes primary ciliary dyskinesia. You're taking the code, the message that encodes that gene, you're putting it inside a particle that then gets inhaled into the lung. It's a lipid nanoparticle. And you hope that that gene then gets transferred into the patient and will fix the problem with the cilia. Very, very clever, really, really amazing science. What was presented at the conference is the results of these 2 studies, phase 1A and phase 1B. Now, what does that mean? This is the first time it's been tried in humans, usually in phase 1A. So the first time it's tried in patients, and phase 1, and that's what phase 1A and 1B mean. You're not looking for clear evidence that it works. You're looking for preliminary evidence that it works and that it's safe, so that you can do larger trials. And so this is the idea. So you have this gene that goes wrong in PCD, DNA-I1. You put it inside this particle. It's nebulized into the patient, and that gene eventually finds its way into the epithelial cell of the lung, and it will make normal cilia and be able to clear mucus normally. So the 2 studies that were done were, the first study was to do a dose of the nanoparticle, and then a bronchoscopy was done in order to see whether you could show that the gene was being restored into the cells of patients, and also asking the patients how did they get on with this? Did they have any problems with it, any side effects? And so these are the results. And I'm sorry to say that it wasn't a positive study. The medicine was well tolerated. So at these doses up to 5 milligrams, there were no major side effects. So patients weren't dropping out of the study or saying, I can't tolerate this nebulizer. There were no treatment-related adverse events leading to hospitalization or other kind of problems. People tolerated the inhalations okay without drops in lung function. But when they did the bronchoscopies and looked at the cells, they weren't able to show, as shown here, that there was a rescue of that DNA-I1 protein. So they weren't able to show that the message was getting into the cells and that it was fixing the cilia. And so that means it's very unlikely then to give benefits to patients. And so it's not clear whether this will move forward into other trials, whether they'll try different ways of delivering it or different patients, etc. Why might it not get in there? Well, getting it into the lungs deep enough and getting it through mucus and things like that can be really challenging. Giving drugs by nebulizers is challenging, and sometimes that's a reason why things don't work. So the conclusion was, this is an achievable thing to do. You can give this into the lungs, but you need to understand how best to deliver it, how best to get it into the cells, how often you need to dose it, those sorts of questions, if we're going to be able to do this in future. And I really hope that we are, because this could be, if we can get this to work, it would be almost a cure for primary ciliary dyskinesia. Okay, so from bad news to really good news, let's switch to NTM. I'd shown you at a previous webinar that I did for Running on Air. I love when we have a beginning of the story and the end of the story. The results of this trial that came out last year called the ARISE trial. And this was in people with MAC lung disease, so Mycobacterium avium complex disease. A small trial, 48 patients and 51, where they tested whether giving ALIS, amikacin liposomal inhalation solution, as part of standard of care for NTM in people who'd never had treatment before could improve symptoms and get rid of the bugs, get rid of the NTM more effectively. And what they showed was that the quality of life questionnaires worked well, but that you also had a higher rate of eradication of the NTM, clearance, culture conversion of the NTM by month 7 in people that got the nebulizer versus people that just took oral drugs. So that was really exciting, but that's a small study, so it needs to be confirmed in a larger study. And probably the headline in respiratory infection bronchiectasis at the ATS was the results of the ENCORE study, which is the follow-up study to this. So ENCORE was a randomized trial, very similar to ARISE, of people over the age of 18 with MAC, so with Mycobacterium avium lung disease. They had to test positive for MAC. They had to have symptoms at the start of the trial, so the ability to respond to a therapy. And they had to have newly diagnosed or untreated MAC, so they couldn't have refractory disease or relapse of previous disease or lots and lots of previous MACs. The bug had to be susceptible to amikacin, so amikacin had to be the right treatment, and they couldn't have big cavities on the lungs. So with all of those things in mind, then patients were randomized to this trial and got one of two things, and it's a blinded trial, so they didn't know what the patients were getting until the end. So they either got azithromycin and ethambutol, which are two of the standard oral drugs that we give for NTM, plus amikacin via a nebulizer, or they got empty liposomes by the nebulizer, essentially a placebo, plus azithromycin and ethambutol. So that's a very fair test, because the only thing that's different between these groups is the amikacin. And they took that, and there was 213 patients in the ALIS arm and 212 patients in the control arm, and they were treated until month 12. So after a year of treatment, we saw how did they do from a symptom point of view, and the primary endpoint was symptoms, and then how well did they do in getting rid of the MAC. So as I say, the primary endpoint is the symptoms, the secondary endpoint is culture conversion, and does that persist? And then, of course, side effects are always really important in treating MAC, because a lot of the drugs that we give do carry important side effects. So this is what happened. 213 patients were randomized. 174 were able to complete the trial. 212 were randomized in the comparator. 187 completed the trial. So you already see there's a few people that discontinued the ALIS arm because possibly side effects or the burden of treatment. We don't know. It's slightly higher in that group. The majority of patients were elderly. Of course, we know that with NTM, and about 80% were female. Lots of patients from all around the world, mostly white. And you can see symptom-wise, patients were quite sick. So out of a 100-point scale, the average was about 60. So they had a lot of symptoms. And for most people, this was the first time they'd ever been treated for MAC. So about 80% of people, this is the first time they've ever been treated. Some patients had had it before, and you can see the species that are there. The vast majority of people have a diagnosis of bronchiectasis. Of course, bronchiectasis and NTM go hand in hand. So what happened? Yeah, is it good news or bad news? Well, you can probably guess from how I'm speaking that it was good news. So the primary outcome was respiratory symptoms measured by the quality of life bronchiectasis respiratory symptom scale. And these are the differences. Remember, both of the groups are receiving treatment. One group's getting rifampicin and ethambutol. One group is getting those two drugs plus ALIS. So any positive number here is an improvement in symptoms. And we usually say about 8 points is a big improvement. So the first thing to say is NTM treatment really works. Like, people feel a lot better. So even this is a month 13, so 13 months after treatment, a 14.5-point improvement just in the comparator arm means patients are feeling a lot better, even without the ALIS. But if you give the ALIS, they feel even better, 3 points better. Now, 3 points is not huge, but it is statistically significant, and it means that, you know, some patients will notice a big difference, some people will notice less of a difference, but there is a difference between the groups. So the trial was positive because it met its primary endpoint, which is always important. And this is the improvement 15 months out, and it's slightly higher at that point, the longer you get away from the end of treatment. And that's probably because, as you'll see in a moment, the ALIS arm was better at getting rid of the bugs, so they can keep the symptoms away for longer. And here the difference is 4.8 points. So what about getting rid of the bugs? And this is a really important part of NTM treatment. This is why we give antibiotics for NTM, is, of course, we want people to feel better, but ultimately over the long period of time, you want, and the patient wants, not to have the bug anymore, because then the symptoms should follow. And so what happened? Well, these are really exciting results. So the treatment success normally for MAC, I say to my patients, around 2/3 of people will clear MAC over the course of a treatment. Now, these data suggest that I'm broadly right with that, because overall at 12 months, which was at the end of the treatment, 61% of people in the control arm had cleared the MAC. So the 2/3 clearing it means that 1/3 of people don't clear MAC and are stuck with it. They're what we call refractory. So taking the nebulizer, ALIS, really reduced the proportion of people that were not able to clear the MAC. So the number of people who had ongoing problems. And the differences here are pretty big. So at 6 months, 30% more patients got rid of their MAC with the ALIS compared to the comparator. At 12 months, it's still about a quarter, it's still about 25%, and the same out to longer time horizons. So even after you stop the medicine, you know, the bug is gone, it's not coming back in the vast majority of patients, and that's really encouraging. So it tells you that if you're able to use this nebulizer up front, a lot more patients are going to be cured of their MAC lung disease. So this is the first time this has been shown, and suggests an important role for upfront amikacin treatment. And this really illustrates the point that throughout the trial, there's a clear advantage of ALIS over the comparator. So the purple skyscrapers are the proportion of people who've gotten rid of the bug, and the turquoise color is the comparator group. And at every point, every month, the people on the ALIS are doing better, and that's the message of the slide. So of course, the other side of this is side effects. You know, those are really nice results. We want people to feel better, and we want them to get rid of the bug. But if they've got terrible side effects, that's not going to work for us. So how did we get on in terms of side effects? Well, in general, it's reassuring. It's consistent with what we know about ALIS from having used it as a treatment for refractory lung disease. The biggest problem with ALIS is dysphonia. So what dysphonia means is changes in the voice. So it causes a problem with the voice that's reversible. If you stop the drug, it goes away. Sometimes if you restart the drug, it doesn't come back. But you can see around half of patients reported a degree of dysphonia at some point. Nebulizing medicines also tends to make you cough, and there's increase, as you can see here, in cough. And some of these other side effects are much less common and not so different to placebo. But it would be wrong to suggest that this isn't something with a trade-off. There is clearly a trade-off in terms of somewhat more side effects. And you can see the number of people who stop the treatment is higher in the ALIS group. So some people, these symptoms, the side effects are just too much and they have to stop the medicine. But it's only a fraction of patients. It's 15%. And almost 10% in the placebo arm stopped the treatment, because there's various reasons why you would stop the treatment. So the overall increase in the numbers who had bad side effects is quite small. These are the other special side effects, and it's really reassuring that there's not a big increase in hearing problems, because we always worry about that with amikacin. Bronchospasm means feeling tight after you take the medicine, and that's about double in the amikacin arm. So that's a known problem with inhaled antibiotics. But great news, there isn't an increase in exacerbations, and there isn't an increase in other major side effects. With the exception of, and this has been noted before when using it for refractory disease, is that very, very rarely, some people get some inflammation in the lungs, what we call pneumonitis with ALIS, and that happened in 5 people in this trial. So that's an important thing to warn people about, even though it's rare. So that is a really exciting development. We now have a treatment that means that 80% of people could get rid of their MAC lung disease rather than 60% of people. And that means giving an upfront nebulizer. So it won't be the right treatment for everybody, but it'll be an important treatment for a lot of patients. Now, I showed you in that trial that the control group all got 2 drugs, ethambutol and azithromycin. There's another drug that we use a lot for NTM that's called rifampicin. If some of you have got NTM, you'll have been on rifampicin probably. And so there's a question mark as to whether you need 2 drugs or 3 drugs, and whether there's an advantage of giving an extra drug. Do you just get side effects with no additional benefit? So Emily Henkel presented this on Monday at the ATS. This is a trial comparing 2 drugs versus 3 drugs across the USA and Canada. And this was for MAC again. And the primary outcome for this study was clearance of MAC at 12 months, based on having 2 consecutive negative cultures, and symptoms were the secondary endpoint. And so it was designed to show that 2 drugs was not worse than 3 drugs. So here are the patients, again, age 69, 80% female, and you are said to have followed the dosing regimen if you took more than 80% of the doses. And there's around 200 patients in the study. So what happened? Well, you can see this isn't as good as ALIS. So you're not up at 80%, you're down at 60%. My 2/3 number that I've been saying to patients all these years, again, looks to be about right. So in people that took the medicine for 80% or more of the doses, 2/3 of people cleared it in the 2 drug, and just over that cleared it in the 3 drug. So there's a tiny benefit of taking 3 medicines, but there's no statistical significance there. And likewise, in everybody that was treated, it's slightly lower in people that were treated. So you can argue that the 2 drugs are slightly worse. There's some evidence that the 2 drugs are slightly worse. But the trade-off there is that almost 20% more, almost 1 in 5 more patients were able to finish the 2 drug regimen than the 3 drug regimen, because there were less side effects. There was no difference in symptoms between the 2 groups. So overall, I think this trial supports that you could give a 2 drug or a 3 drug regimen depending on the patient, depending on the trade-off between really wanting to maximize the chances of clearing the bug and the risk of getting side effects and not being able to finish the therapy. So I'm going to finish my talk now with novel antibiotic drugs. So many of you, if you've got bronchiectasis or NTM, will have been on lots of antibiotics. It's the mainstay of treatment for this disease. It doesn't always work, and it causes problems with resistance. So it's quite exciting that there are new developments trying to make us some new types I've called them antimicrobials, because they're not really antibiotics, but they're drugs that kill bugs. And on Wednesday at the ATS, there was a presentation of this new medicine called Respex. So what is this? This is an antibody against Pseudomonas. So Pseudomonas is a big problem for us in bronchiectasis. Antibiotics struggle to kill it. Antibodies are used to treat asthma, they're used to treat COPD, they're used to treat rheumatoid arthritis. So antibodies are a really well-developed type of treatment in lung disease and other diseases, but they're not currently used against bugs. So here's one that's being targeted against bugs. And they did a randomized study where they gave doses of this injection and then did bronchoscopies to look at how much of the medicine gets into the lungs and whether there was any evidence of benefit for the patients. And to cut a long story short, there were no major side effects, which is really good. It seemed to stick around in the body for a long time, which means it should be possible to give either monthly or 3-monthly doses of this. Imagine being able to go from daily nebulizers to 3-monthly injections. That would sound great to me if I was a patient and that was a way of managing my Pseudomonas. And they mentioned, although not a huge amount of data presented, that there were trends suggesting that some people who got the medicine may have had less exacerbations, but much longer studies are needed. But this is an exciting development because it has the potential to treat Pseudomonas in a new way that's less likely to cause resistance. And it's not the only one of these medicines, because there's another new one called AZD0292 that's also currently in clinical trials. So I'm going to finish there and take as many questions as we possibly can. I think this is a thank you to my research group. I think the ATS emphasizes that there's lots of really exciting things happening in NTM and bronchiectasis. Lots of exciting new drugs coming that could make a big difference for patients. The science is really pushing things forward. So thank you very much for your attention.
Thank you very much, Professor Chalmers. As always, quite a wealth of information. And I will say, I think a lot of hope for those of us with bronchiectasis and NTM, and maybe not as much hope as we had hoped for PCD, but you know, we'll see about that. But yes, thank you so much for going over all of that.
I'm gonna jump in there with the PCD and just put a positive spin on this. So almost every treatment that we currently use started off with a failure. Yeah, very few things work first time. So including things like brensocatib that I talked about, you know, those were written off several years ago as these things are never going to work because they had some issues in their early trials, and then, you know, it's flown since then. So I'm positive about the PCD stuff. I think we've learned a lot from that study about how to do it, you know, what problems there are with delivering it, and I think the next one will be better.
So I'm just going to jump a little into a PCD question, since we've got that. We just talked about that. So there was a question, you know, because the trial was for one PCD gene,
Yeah.
and there are over 50 PCD genes. So the question that was asked, would this type of treatment work for the other genes? If not, is it easy to modify this treatment for those? You know, and what happens if a gene hasn't been identified yet?
Yeah, those are really important questions. So the answer to the question is there's over 60 PCD genes that have now been identified, and you'll know that there's many more still to be identified. It's around 70% of people will have a definite gene when they get tested, because so many people have genes that haven't been found yet. This trial was for one particular gene, which is DNA1. It's one of the most common ones. But the wonderful thing about the mRNA technology is that it's very adaptable. So you can take the message for another gene and put that different message inside the same particles and deliver that into the body as well. So the idea with this trial was that if DNAi1 had worked, then they would have moved on and done the same for other genes just by putting a different message into the same packet. Yeah. So this approach has hope for fixing a substantial number of these genes. And there are other companies that are pursuing similar approaches. So there's another one called Ethris, which is targeting a different gene, and then there are others that are targeting other genes. So the hope is that it'll be a set of technologies, the mRNA technologies, that can eventually treat most people. But as the questioner points out, it will only work for people who have a gene that's been identified and people who've been tested appropriately.
All right, thank you. John?
Dr. Chalmers, first of all, I'd like to thank you for your optimism, and you always have a hopeful message. And in a world where patients are so frustrated from years and years of being misdiagnosed, it's always refreshing to hear that you have a positive outlook, and it's very much appreciated. So a question from one of the participants: does Brinsupri help exacerbations that are accompanied with hemoptysis?
Yeah, really good question. So the answer is yes. So during the ASPEN trial, which is the main body of data that we have for Brinsupri, over 1,700 patients took part, and we recorded the symptoms that people had when they had exacerbations. And the exacerbations that were counted had to have one of 6 symptoms, and one of those symptoms is hemoptysis. So if you had exacerbations during the trial and had hemoptysis, you were in the group that was included, and those exacerbations are reduced by about 20% with brensocatib.
Thank you. Mary?
This is about Brinsupri, and when do you think it will be available for patient use in Europe? I read, and they said they read the pharmacies are not even applying for reimbursement yet. But
yeah, so this is really upsetting because of the sort of reimbursement situation. So there's currently issues in relation to being able to change the price of the drug between Europe and the United States. There's been no launch of the medicine in Europe yet. We're hoping that situation will change, and there's intense, campaigning, lobbying going on both sides of the Atlantic to try and change that situation. What I would say is don't give up hope. I'm very, very positive that there will be a solution in the very near future to allow some patients in Europe to get access to this medicine. I have to say the company have been very proactive in recognizing that people all over the world took part in these trials, and so people all over the world need to have access to the medicine. And I believe that's something that we as clinicians believe, but I also think it's something that the company believes, and so I believe we will find a solution very soon.
if living in Ireland, can you get on a trial?
Yes, you definitely can. Ireland has been really unlucky over the years. Companies make decisions about where to go for trials based on what's happened in the past. And so Ireland has not traditionally been part of a lot of these trials because they weren't in some of the older trials, and so people haven't been going there. We've actually been doing some work with Melissa McDonnell, who's a wonderful doctor in Galway in Ireland. And we've managed to get a set of sites in Ireland to get signed up into the trials that are coming. So I would speak, if you're in Ireland, I would speak to your consultant and find out which trials are available, because I know of 3 trials that have just started to set up in Ireland because of the work that Melissa's been doing.
So, Dr. Chalmers, the ASPEN trial for Brinsupri excluded patients who were receiving active treatment for NTM disease, but were patients who had NTM infection but were just being monitored rather than treated included in that study.
Yeah, so I see that question's from Linda. Lovely to hear from you, Linda. Well, the answer is yes. So people in that trial couldn't have active NTM, meaning that they were being treated, but they could have NTM incidentally in the sputum or NTM in the past. So my understanding is that data has been collected and that there's going to be some of that data released later this year, I hope, fingers crossed. And so that data will be coming. It's not going to be perfect because patients weren't systematically tested for NTM as part of that study, but it'll give us some information. I really do think, and I've talked about this before, that we need to think about a trial of brensocatib or similar drugs in people specifically with NTM, because this question comes up all the time.
Can brensocatib be taken if someone is being treated with voriconazole for chronic pulmonary aspergillosis?
Yeah, so two comments to that. So one is, can it be taken? Yes, but there is a possible interaction between the two drugs. So you would need to discuss it with your doctor, and it would probably have to be reviewed by a pharmacist, because there's a theoretical interaction between the two drugs, which can reduce the effectiveness of the treatment. So that's important. The other part in terms of discussing with the doctor is that we excluded people with active fungal infections or ABPA from the trial. And so there's less information about how effective it is in that group. So that's one that needs to be carefully discussed with a specialist.
Is there any evidence that brensocatib or any of the DPP-1 in class of medications impact cognitive decline?
Unfortunately, I don't think we looked for that. I don't think there's any evidence of that. I will say there is an association between feeling unwell, repeated exacerbations, loss of ability to exercise, etc., and cognitive decline. So as a patient, the best thing that you can do to maintain the brain cells is to exercise regularly, eat a good diet, and try and keep yourself as healthy as possible. And taking these medications may be part of that. So an indirect effect of being healthier may well be that you just feel a bit more able to do those things that we know do impact on cognitive decline.
But so here's a question: is they're asking if it's possible, somebody who's taking Brinsupri and has had benefit, if it's possible that it can eliminate right middle lobe collapse that still causes shortness of breath. I know that there was, part of the study did look at CT scans. So that may not be something specifically, but maybe if you could address that.
No, for sure. That's a really great question, and we do have data on that. So 100 people in the study got CT scans at the beginning and at the end. And the data were really exciting because in the people who took the 25 milligram dose, which I said earlier is the dose I think I would take if I was a patient in the US, there was a reduction in mucus plugging. Yeah. And so your question is about right middle lobe collapse. In most people with bronchiectasis, collapsed lobes are caused by bits of mucus blocking the entrance to the tube. And so Brinsupri reduces the blocking of tubes with mucus. So it could theoretically help to relieve those kinds of problems. And we saw that in the CT study.
That's exciting news.
So would Brinsupri still be effective if the patient is colonized with Pseudomonas? The Pseudomonas is untreated as the Toby podhaler isn't available at this time, and I assume she means where she lives.
Yeah. So yes, in the trial that we did, our wonderful patients all gave a sputum test at the beginning of the trial to test whether they had Pseudomonas or not. Because when we designed the trial, I really wanted to be able to answer the question about Pseudomonas. So thank you, Jenny, for giving me the chance to answer the question, because we prepared for this 5 years ago. So 1/3 of the patients tested positive for Pseudomonas, and the drug was just as effective in the people that tested positive as in the people that tested negative. So it works just as well in people with Pseudomonas. And it's lovely that we were able to do that test to be able to answer that question.
Thank you.
Has it ever been possible to gain weight when MAC and lose weight when taking either prednisone or dexamethasone? Yeah.
Is it possible to gain weight when taking MAC? Yes. A lot of people lose weight when they've got NTM infection, but there's nothing as diverse as the human race. In diseases where 90% of people lose weight, there will be 1 in 20 people who gain weight. There's just no rhyme or reason to what happens with people. But in the case of the question there, if you're taking prednisolone, that really boosts appetite. So steroids have a big effect on appetite. So if you're taking MAC treatment, which would usually make you lose your appetite, but you're taking prednisolone, the prednisolone will probably have a much more profound effect on boosting appetite, and that would be why you would gain weight.
Okay, this question came in when you were discussing the ALICE trials. And the question is, how well does this work for people with resistant MAC?
Great question. So all of the people in the trial had to have sensitive MAC, at least to amikacin. Okay, so we wouldn't use amikacin in somebody that's got a highly resistant bug against amikacin, because the assumption is it wouldn't work. So all of these patients had a sensitive bug. We sometimes struggle with language here, of course, don't we? Because you might mean by resistant one that's not responded to the first line treatments. And we know in the US and in Europe, where I work, ALICE amikacin is approved to treat what we call refractory MAC, which is MAC where people have taken at least 6 months of treatment and it hasn't gone away. And that's true resistance. You know, that's, you've tried to treat it and it's been resistant to the treatment. So it works really well in that scenario. What these trials tell me is that if cost is not a factor, you would want to take the amikacin nebulizer as your first treatment, and or if you're not responding to treatment, it would also be part of the regimen as long as the bug is still sensitive to it.
How common are bronchospasms with various nebulized treatments, including typical albuterol, levobuterol, etc., or even with hypertonic saline?
Yeah, great question. So really important question. So your lungs are designed to keep things out. Yeah, so your lungs are designed for only air to go in. Your lungs don't like anything else going in. And so they react to most things that are inhaled. So the safest things, of course, are albuterol and other bronchodilators, because they actually open up the airway tubes. But even a couple of % of people can have what's called paradoxical bronchospasm to those medicines, where the lungs react to the medicines more than the medicines work. But that's the rarest thing. The most common things that people react to are things like amikacin and tobramycin. So those are a class of drug that we call the aminoglycosides, and they're the most irritant drugs to the airways that we have. And it's about 1 in 5 people consistently find that they get bronchospasm, meaning they feel tight or they cough with those drugs. And that's exactly what the amikacin trial showed. And it's what my TOBI bronchiectasis trials have shown. Hypertonic saline, you get less bronchospasm. We did a big UK trial of over 100 people on hypertonic saline, and only about 5 or 10 patients got bronchospasm. And it wasn't predictable at all. It can happen at any time. Some people just start reacting to their hypertonic saline, but it's not common. Most people get on okay with hypertonic saline. So that's the story. Most people will be fine, but up to 1 in 5 people will get bronchospasm with these drugs. What you can do to protect yourself is to take a nebulizer like albuterol before you take the other drugs, because it helps to protect the airways. And the other thing that's a good idea to do is to do good airway clearance before you take your nebulized drugs, because what you don't want is you're putting in a big load of drug into the lung. What you don't want is it all just gets caught by a big plug of mucus, and the whole dose of the drug hits one bit of the lung where all the mucus is. You want it to spread nicely throughout the lungs, which means your lungs need to be clean with not too much mucus for it to stick in. So if you do that, if you do your airway clearance and you do your bronchodilators, you probably get less of the bronchospasm.
That's really helpful to hear that. And what's frustrating as a patient is when you're 10 or 20 years into this and somebody finally gives you these instructions. You think, why didn't I know that ahead of time? But I'm glad you're bringing that out, because so many of us don't get good instructions up front. And I did not write the next question, but I could have. Have there been any? Go ahead.
Could I just comment on that, John? Because I think that's
Absolutely
important. If anybody's listening to this, it's so common that patients come to my clinic and say, well, I tried that tobramycin and I just can't take it. It's terrible for me. Or I've tried that hypertonic saline and it's terrible for me. And I show people what to do, how to do their airway clearance, how to do the nebulizer. And they go and I say, trust me, trust me, we'll give this a try. What's the worst that can happen? And they come back and go, it works. I've got no side effects. And it's exactly as you say, John. But for people on the call who've maybe had a problem in the past, and think I could really benefit from one of those things, it's never too late to try some of these little tips and tricks that can maybe allow you to use one of these medicines that can be quite effective. Sorry to interrupt, John.
No, that's wonderful. And it seems like there's it's such a delicate balance of getting the order of things right, getting the intensity and all these other things. And when we're in the appointment with the doctor, we're so overwhelmed. It's hard to process all of that candidly. So we do appreciate it. Okay, this question goes right to my heart. Have there been any new studies on Mycobacterium abscessus, subspecies abscessus? Because we hear so much about progress with MAC, and these new developments, do they go right to abscessus, or are they only being allowed in the MAC world?
Yeah, so MAC is more of a work in progress, I would say. So there is an international platform trial. So platform trials where you test lots of different drugs, that's looking at new treatments for Mycobacterium abscessus, but it's early and they haven't got really advanced results as yet. Theoretically, this drug amikacin can also work in Mycobacterium abscessus. So I'm very hopeful that what we've just seen, these trials, may well eventually be extended to Mycobacterium abscessus. So I'm with you, John. Abscessus is the most difficult thing that I treat, and it's something that we desperately need to do more trials on.
Can you expand on ototoxicity risk for amikacin, and if already hearing impaired and experienced hearing loss with azithromycin and tobramycin?
Yeah, so this is really tricky. So amikacin given via an intravenous infusion, so given via the vein, one of its major side effects is ototoxicity. And what it does is, you've probably all been told when you're younger that your hearing is through little hairs in the middle of your ear. And what I was taught is that the amikacin just kills the little hairs. Okay. And so it causes that neurological or sensory neural hearing loss. That's the same mechanism by which azithromycin can also cause hearing problems. And so sometimes in NTM, when people lose their hearing and they're on both of those drugs, it's quite hard to figure out which is causing the problem. With ALICE, quite reassuringly, the hearing problems was about 25% of people in the ALICE group, but it was about 20% of people in the comparator group. So what that tells me is that people do lose their hearing or are having problems with hearing while they're on NTM treatment, but it's not the amikacin via the inhalation that's causing the problem. It's either the azithromycin or dare I say it, please don't be offended, that some patients in those trials are a little bit on the older side and maybe losing some of their hearing over time anyway. So I think the data on ALICE is quite reassuring, but this is something that we see regularly when treating NTM. So very important to report it to your doctor. And if you're getting tinnitus, which is often the first sign, we need to change the drugs at that stage so we can preserve the hearing loss, as much as possible.
Now, you mentioned in your talk that ALICE and other inhaled aminoglycosides often associated with dysphonia, the change to your voice. Do you have an idea of what the mechanism is that's causing that?
We don't really. It's presumed to be a direct irritant effect, but it's very specific to amikacin. So you get a degree of dysphonia with a lot of other nebulized medicine, but it's in the 5-10% range, whereas amikacin is consistently in these trials about 50%. It's almost everybody is getting a degree of this. The good news is that for many people, it just goes away or it settles after you've stopped the drug for a short period of time. So it doesn't mean that people have to stop taking it. But it's a frustration. I wish we could design a version of this drug that doesn't have that irritant effect.
I'm going to kind of combine the next two questions because I think they are somewhat related. So the monoclonal antibodies studies. Somebody's asked about where the research is being done, and I know there are trials going on right now in the US and Europe that are currently enrolling. And then the second, so if you can speak a little more on that, but the second part of that is asking when the drug for Pseudomonas would be available for patient use.
Yeah, great question. So the early trial that I showed you was done in the UK. I wasn't involved in that one, but it was done in the UK. But what you just said, Mary, is absolutely right. There's two of these medicines, which are the antibodies against Pseudomonas, and one of them, which is AZD0292, is currently in trials in the United States and in Europe. And it's in the phase 2 trial phase, which means that it's at the later stage of development. And it's at that later stage of development in a trial of 450 patients, because the early trials showed really exciting results. They actually improved symptoms by 12 points on the St. George's questionnaire, which is huge. It's one of the first trials I've ever been involved in where patients were phoning me up at the end of the trial and saying, you have to keep me on this stuff, James, because it's just made such a difference for me. And that doesn't happen very often. So this is available right now. If you talk to your doctor about whether they're participating in the trial or whether they could refer you to somewhere that's participating in the trial, it's a monthly injection that controls the Pseudomonas. And it's being tested in, as I say, this phase 2 trial. So
right. And
when is it likely to be available? So the process is always phase 2, then phase 3, then availability. So we would normally say 5 or 6 years between phase 2 and getting out there properly. But go do the trial, because that means you can get access to it now.
yeah, and I when we send the email out on Friday, we'll have a link to clinicaltrials.gov, which is here in the US, but obviously you can access that from anywhere. And we'll have some of the specific links on that website for these trials. And it'll list the sites. I think they list the sites around the world. So it's not just US sites, but they'll list sites around the world where you can reach out to see if you can get into one of those trials.
So I'm going to paraphrase the next question, but I think I have the meaning here the same. In the initial trial for Alice, that's the brand name Arikayce, there was a comparison to its effectiveness versus inhaled traditional amikacin. Could you comment on the relative effectiveness of those two medicines?
So in the trial that I showed, there's no comparison with the intravenous type of amikacin that's put into the nebulizer. So it was compared against what is current standard of care, which is giving the tablet antibiotics. So actually the sort of what a lot of doctors have done before Arikayce was put the intravenous formulation into a nebulizer. It's often not very well tolerated. The dysphonia is even worse. The bronchospasms even worse. So there's no head-to-head that I'm aware of that's looked at those two medicines. But of it, there probably won't be, because the intravenous formulation is not approved and not designed to be nebulized.
Okay, thank you.
Before I ask the next question, I am going to take the opportunity, since we did talk about trials, to just put in a plug for people to sign up for trials, because as Professor Chalmers said, it gives you potential access to the treatments now. A lot of these, the phase 2 trial is looking at the actual drug and a placebo, and so you're not guaranteed of getting the drug, but sometimes after the trial's done, companies do make it available for the people who were on the trial, as long as everything has, is looking safe. And I know that Insumed did that with brensocatib. And, so you don't have that. It was nice for those people because, and you got it whether you were on the placebo or not after the trial was done. So you knew you were getting the drug. And it's nice for those people who had benefit, like Professor Chalmers, you mentioned your patients with this one, because it can be disappointing to feel a benefit from a drug in a trial and then still have to wait 5 or 6 years to be back on it again. So, it's not a guarantee that they offer it, but that could be one of the benefits. But of course, we can't get any of these drugs approved if people don't join the trials for them. So that's my little plug for participating in trials.
Very well said, Mary.
Okay. So this person, I've heard that the French health authorities have refused the authorization of brensocatib in France. Do you know if that means that it will never be available in France?
Yeah, so that's correct, but it's the same situation in a lot of countries, that it's more about the reimbursement. So when somebody says this is how much the drug is going to cost, the health authorities will make an assessment of, is the drug's benefit worth that amount of money? And the French authorities have said no. And because of the regulations that I mentioned earlier, it's not possible currently for the price to be changed. And so that's the stalemate that we currently have between Europe and the regulatory authorities. So I'm hoping that will change. I would be very, very surprised if this isn't available in France in the near future.
Would the antibody treatment that you mentioned be specific to the individual bacteria species?
Yeah, that's right. So the ones that I showed you are only for Pseudomonas. So unlike antibiotics, which kill lots of different bugs, the antibodies are very specific against one bug. And that's probably a really good thing, because you have both bad bacteria and good bacteria in your lungs. And something that a lot of us worry about, and I know a lot of my patients worry about, is when you take a lot of antibiotics, am I just wiping out all the goodies as well? And so these antibodies won't do that. And that's one of the things we looked at in our antibody study. We actually saw the good bacteria started to come back after 3 months, because we'd gotten rid of the Pseudomonas that was probably holding it down. So hopefully they'll be good for our microbiome, to use that word.
Now that's different from still being studied phage or phage therapies, because they have to find a particular phage to match the specific type of Pseudomonas. So one specific phage will not work for all types of Pseudomonas, but here it sounds like these antibodies will.
Yeah, so that's right. So the antibodies, you don't have to do any matching. So we did some studies showing that 99 out of 100, 99% of people with bronchiectasis have bugs that are sensitive to these antibodies. So there's virtually no resistance to these antibodies. So they'll work for almost everyone,
Okay,
which is great.
Mary?
All right, thanks, John. I was about to say I lost track of whether it was you or me.
I think it's you.
Okay. Do doses of ARIKAYCE need to be adjusted by patient weight? And can you measure systematic ARIKAYCE to monitor side effects?
So you can measure amikacin levels in the blood, and that's something that we do when we're giving intravenous amikacin as a treatment. So yeah, that's correct. The dose of amikacin is usually a standardized dose, so it's not adjusted based on weight for the nebulized form, but it is for the intravenous form. I assume you're talking about the nebulizer here. So the idea is that you're delivering it to the lungs, so very little of it should get into the blood. And so if you would only measure it in the blood if you had reason to believe that somebody was having toxicity problems and you thought an unusual amount of the drug was getting into the blood, which tends not to happen.
So how is the pulmonary exacerbation improvement measured?
Okay. So in the clinical trials that I've been talking about, patients obviously were given the contact details of their doctor and told if you feel like you've got an exacerbation, please let us know. And then the doctor made an assessment of whether that was an exacerbation and how many symptoms they had and gave an antibiotic. But in addition to that, patients filled out a daily diary with 5 questions on a smartphone or on a tablet to say how are they feeling. And this was to make sure we didn't miss chest infections where people felt awful but didn't report it to their doctor or got antibiotics from somewhere else. And so that was also used to capture exacerbations. So it was quite comprehensive to make sure that we got everything.
So this is a question about using azithromycin 3 times a week. And will it affect the use of azithro if I'm diagnosed with NTM?
So great question. The answer to your question, believe it or not, is probably not. It can do. And so we tend to avoid giving azithromycin if we know somebody's got NTM, because we want to keep the azithromycin back in case we need to treat the NTM. But in the vast majority of people who develop NTM while on azithromycin, it still tends to be sensitive to the azithromycin for various reasons. So I wouldn't stop your azithromycin just because you're scared of NTM. In actual fact, Mark Matursky, my good friend, did a study using the US registry data and showed that people who are on regular azithromycin are less likely to develop NTM. So it probably has a kind of protective effect. So although the concern is a valid one, I definitely wouldn't stop your azithromycin because you're worried about what might happen in a few years with NTM.
Boy, that's good to know. Next question. It sounds promising that more people will convert to negative MAC with ALIS taken from the beginning. You don't know how long that will last because you haven't studied it as long. What can you say about the length of time in between treatments?
Yeah, so in that trial that I showed you that's called Encore, they treated for a year and then they'd followed people up for several months post-treatment, and it still seemed to be clear. But there was a small number of people who did test positive again. That could mean that the bug is coming back, but it's more likely that some people are becoming reinfected, because 1/3 of people who have an NTM and get it cured will get another infection at some point in their lives because you're still being exposed to NTM and you still have bronchiectasis. So that's a little bit complicated to figure out what's a failure of treatment and you didn't treat long enough, and what's just that you've gone back into the garden or you've gone back to the showers and you've been exposed to NTM and you've picked it up again. So I think over time, undoubtedly, even with the best drug in the world, after you stop it, some people will get NTM again because it's everywhere in our environment.
But I'm going to skip one, John. I'll let you ask, or why don't you go ahead and just ask the next one because it's still kind of same topic.
On the mRNA or the ALIS?
The ALIS.
The ALIS question. So with ALIS, is there still a concern that dosing less than daily to improve tolerance may raise the risk resistance?
Yeah, so there's always worries about resistance with NTM. So that is always a concern. Pragmatically, if somebody's on multiple drugs, the risk that changing the dosing of ALIS because of tolerability problems or stopping it for a period because people have dysphonia, that will cause resistance, the risk is very, very low, actually, because the bug is still being exposed to several other antibiotics. And so the bug doesn't have the chance to adapt. So we often have to make changes to people's regimens. and it doesn't tend to result in issues around resistance. But I've just found the question now, any plan to study the effectiveness of a 3 times a week approach? I suspect not, although it would be lovely to be able to modify those sort of regimens and make them easier to take. It's very hard to do those kinds of studies. That's the sort of thing that we as doctors probably have to figure out pragmatically with patients. So for various inhaled antibiotics, I have people on 3 times a week. I have people on once a day rather than twice a day. But it's things that I've worked out with patients because it's the best way to manage them rather than something that we do in randomized trials.
Thank you.
So this one is about side effects of Brinsupri. What is the evidence for actinic keratosis as a side effect?
Yeah, so actinic keratosis is a kind of precancerous skin problem. There isn't very strong evidence at all that this is an issue with brensocatib or any of these drugs. The most common skin problem with Brinsupri is what they call hyperkeratosis, which is thickening of the skin. It can look a bit like these things, but this is actually a non-cancerous. It's a completely benign condition where you get sort of red patches or redness or thickening of the skin. Sometimes it's on the hands and feet, but actually it can happen anywhere on the body. Obviously, there are cautions around various skin problems with Brinsupri because we've only used it for a year in the trials. And so people are being monitored for any kind of skin side effects, and there's warnings in the FDA label around skin problems. But in general, they're minor. Then there's no evidence that they lead on to cancerous problems, and they don't tend to mean that people need to stop the medicine.
Okay, so the next patient has had some significant treatment for Mycobacterium abscessus, and her question essentially is: are there any new treatments in the works for abscessus? She's lost weight, she's lost her hearing, lots of side effects. Do you have something to tell her that there's a new treatment in the process?
I'm so sorry for the experience you've had. As I said earlier, abscessus is a terrible, terrible condition that's very, very difficult to treat. So there are trials going on. As I mentioned, there's this trial run out of Australia that's recruiting all around the world with a few new treatments for abscessus. There are some trials coming of new antibiotics, including the inhaled antibiotics for abscessus. But at the moment, it is finding a combination of antibiotics that your bug is sensitive to and that will work. So I can see the ones on the list that you've tried. And those are again, difficult medicines to take, and I can see why you would have side effects with those. Important to talk to your doctor about what other antibiotics are available, because there are a lot of different antibiotic options that can be tried beyond the ones that are on that list.
We are getting close to 2 o'clock, so I think we have time for a couple, 1 or 2 more questions. I'm going to skip down one because I think this is an important question to kind of clarify. Can Brinsupri help clear Burkholderia septicemia? And I probably butchered that. That is colonized for 5 years. Well, that is colonized, and sometimes I guess with hemoptysis, or is the medication Brinsupri only for Pseudomonas?
Yeah, great question. So Brinsupri is for bronchiectasis people who are at risk of exacerbation, regardless of what bug is in the body, because it's anti-inflammatory. So all bugs cause inflammation, and it blocks the inflammation regardless of what bug is causing that. So don't get the message that you have to have a particular bug. Anybody who's got problems with mucus and exacerbations can benefit from Brinsupri. I'm guessing that the question is being asked from somebody's personal experience. I'd be grateful if I would suggest anybody who has Burkholderia cepacia should talk to their doctor about a test for cystic fibrosis, a sweat test or a genetic test. The only patients I've looked after I look after a clinic of 1,000 people. I've probably looked after 10,000 bronchiectasis patients in my life. The only patients I've ever seen who have Burkholderia cepacia have a form of cystic fibrosis, even if it's a mild form with rare genetic evidence. So if they don't have a formal diagnosis of CF, it should at least be investigated.
I'm going to jump in and just ask a question about that with CF. Do you and you know there may not be evidence for this yet, but you know there's been new talk about being tested. Some people with bronchiectasis may have one of the you know, CF gene, and that, you know, so could that bacteria maybe be affecting people with the CF gene, but they don't have CF?
Yeah, so we now recognize that it's a spectrum. So we used to talk about non-CF bronchiectasis and CF bronchiectasis as if they're two different planets in different solar systems. Now we realize that many people with bronchiectasis carry one of the genes, or they carry a gene and a mild gene. And so where do you know, and their sweat chloride, which is the measure of whether your CF function is right or not, is right on the borderline. So how do you decide who's got CF and who doesn't have CF? You know, what's mild CF versus what's bronchiectasis with abnormal CFTR function? And so there's lots of my patients and lots of patients with bronchiectasis fall into that gray zone. And it didn't matter that much in the past when we were treating both with the same antibiotics and the other treatments. But now we've got amazing drugs for CF with the CFTR modulators that it really matters. So it's for us as physicians, it's a disaster if we miss a CF diagnosis, because there's so much that we could do to help. So that's why, you know, in our new guidelines that I talked about the last time, we really emphasize testing more people for CF. And in scenarios where you grow a classic CF bug, or you have problems with infertility or very severe upper airway disease, which can suggest CF, it's really important that people have a CF test.
All right. Well, we are two Eastern time in the United States. So I want to thank everybody for the questions, and I do want to just let Professor Chalmers know we at least answered more questions than are still remaining. So maybe there's some progress there. Oops, somebody just added one. Okay, but we're still ahead of the game. So as I mentioned, we are going to look at doing a webinar just to answer your questions later in the year. And we'll go back to some of these questions that we didn't get answered today and try to like summarize and combine some of them to get those answered for everybody. But I want to thank Professor Chalmers, as always. I mean, this was great, very enlightening and very helpful. And I also want to thank John and Joanne, who are both new to our Running on Air's webinar format, and for stepping in to help, and John for helping NTMIR out with their portion today and the questions.
It's great to be here. Thank you both.
All right,
Thank you
take care.
so much. It's always lovely to speak to you.
Thanks,
Bye-bye.
everyone.
Take care, everyone. Bye.